This is going to be topic 36, hematology, bleeding disorders.
Key concepts. Upon completion of this chapter, you will understand that hematological disorders vary in nature and severity, but affect the entire organism. That hemostasis includes primary and secondary methods to stop the bleeding and then stabilize the clot. How hematological disorders may be subtle and require a good history to support a suspicion of bleeding disorders. Chief concerns: coagulopathy is any bleeding disorder due to the coagulation cascade or coagulation problems. Management can be challenging on this. Knowledge of these disorders can provide the tools needed to manage hematological disorders. Coagulation system review. The body uses a mechanism to maintain hemostasis, preventing blood loss from bleeding. Primary hemostasis depends on the interaction between the innermost layer of cell lining and the blood vessel and the circulating platelets in the blood. So these three have to communicate normally. Secondary hemostasis, the goal is to strengthen the clot plug in the damaged vessel and to ensure that it is not dislodged. So even if we do clot appropriately, if the clot dislodges, it can cause complications on down the line, as we learned in the last chapter. The coagulation cascade is a series of clotting factors or proteins that change form. An example of this would be from factor 12 changes into factor 12A, thereby activating the next step in the cascade. So cofactors get involved in this. It goes from one to the next until it forms something called the common pathway. Once we form the common pathway, then the clot is formed. It's a lot easier. So whether it was from an outside source or an inside source, whether the platelets initiated it or the tissue initiated it, the common pathway is formed. Fibrinolytic pathway allows the body to keep the coagulation cascade in check, and this would be the formation of plasminogen to plasmin. Anytime the plasmin is formed, it will break down the clot. That's what it was designed to do, so that we find plasminogen in various areas. It's in the platelets, it's in the tissue, running around in the blood system. So example of this would be tissue plasminogen activator. The only thing that does is activate the plasminogen that's in the tissues. And then what the plasminogen does is it actively forms plasmin and breaks down the clot. We're going to look at two figures, 23.1 and 23.2. Figure 23.1 is the coagulation cascade, and 23.2 is the fibrinolytic pathway. And this is him. This is 23.1. Activating factors, factor 12, 11, all of these are vitamin K dependent. And then these right here are cofactors. So from 9 to go to 10, it requires cofactor 8. Tissue factor, this would be from the actual tissue itself. This would be from activation pathway or the platelets. And this right here is a common pathway, so factor 10 and factor 2. And this still needs a cofactor, which is cofactor 5. So once 2 is formed, then fibrinogen gets changed to fibrin. So there's lots of checks and balances in this whole cascade. Cross-linked fibrin, and this is the fibrinolytic pathway. So this is the actual clot here. And the only thing that we need to do is take plasminogen and make the active form of plasmin. So what TPA does, tissue plasminogen activator, is it activates the plasminogen into plasmin. And what that does is it breaks down the fibrin links in the clot. Hereditary and coagulation disorders. They're caused by inherited deficiency in the coagulation system. Hemophilia A affects approximately 1 in 10,000 males and is a deficiency in factor 8. Hemophilia B, inherited deficiency in factor 9, much more rare than hemophilia A. Hemarthrosis, bleeding into larger joints. And then we have von Willebrand's disease, hereditary coagulation disorder that results in the lack of the von Willebrand factor in the inner lining of the blood vessels, and the von Willebrand factor is important in platelet adhesion, so it assists and facilitates platelet adhesion. And those are kind of like the emergency patches of the coagulation system. Acquired coagulation disorders develop secondarily as a result of another disease process or condition. Examples of this: thrombocytopenia, which is decreased level in circulating platelets. Idiopathic thrombocytopenia, purpura. The body's immune system is triggered to develop an antibody to its own platelets, so it starts attacking itself, usually through an infection or some other attack to the immune system. We also have heparin-induced thrombocytopenia. Occurs when a patient is taking the anticoagulant heparin, and then they develop antibodies to heparin. Dysfunctional platelets also come in mind. Chronic disease, it disrupts the platelets' ability to function properly. Disseminated intravascular coagulation. I'm going to read this and kind of explain this a little bit. Condition in which there is an overactivation of both the coagulation and the fibrinolytic system. So essentially what you have is you have somebody that whenever they're in DIC, whatever triggered it, there's multiple causes. The platelets themselves start adhering and forming clots. So any organ that would filter the blood now is clogged up and going into failure. At the same time, you just run out of your own clotting factor. So if you got there from trauma, this could be devastating. Purpura-fulminans, which are widespread arterial and venous thrombosis and occlusion, producing a purplish discoloration to the affected areas, and this is something that we can see in DIC. And then last but not least, circulating anticoagulants. Group of proteins that shift the balance from coagulation to fibrinolysis system, and then more towards the clotting side. So any of these systems can give us coagulation disorders very, very easily. Anemias, decreased hemoglobin, whether it be acute or chronic. Chronic anemia is due to a variety of causes: nutrient deficiency, chronic gastrointestinal bleeding, heavy menses are the three top causes, or the three most common causes. Acute anemia occurs as a result of either acute blood loss or acute red blood cell destruction. Congenital hemolytic anemias, anemia caused by rapid red blood cell destruction or hemolysis. When the condition is active, very quickly you can lose large amounts of red blood cells. Sickle cell disease, percentage of the normal hemoglobin in the red blood cells is replaced by a different form of hemoglobin, and this is called S-hemoglobin. And we have crises with sickle cell. First of all, chest crisis, chest pain that is sharp and may change with inspiration and expiration, fever, a productive cough, and other signs of pneumonia. Abdominal crisis, an infarction of a portion of the abdominal organs. Aplastic crisis, a massive red blood cell hemolysis that is often precipitated by a viral illness. G6PD deficiency. G6PD is an enzyme, glucose 6-phosphate dehydrogenase, enzyme required for one pathway of energy production within the cells, and the red blood cells are completely dependent on this pathway. Other biochemical methods of creating energy would damage the hemoglobin. So this is what allows the red blood cell to stay oxygenated. Other red blood cell disorders, methemoglobinemia, form of hemoglobin that's not able to carry oxygen, often occurs after there's been a stressor on the red blood cells, and this can be also caused from medication. Polycythemia, which is an increased amount of circulating solid blood components, and that's like red blood cells and things like this. It's a compensatory mechanism for COPD. Now, we used to call these patients pink puffers. The reason we would call them pink puffers is because their skin was really pink, and I'll explain that in a second, and that they pursed their lips or they puffed. Now, the pursing of the lips is from the disease emphysema, and the actual redness of their skin is from an increased supply of red blood cells. Now, the kidneys at some point identified that the patient was hypoxic, released EPO, bone marrow kicked into play, and made more red blood cells. Normal red blood cell count is about 40% of the circulating volume of blood, but in the patient that's polycythemic, we may find higher ranges on this. This thickens up the blood, makes it more viscous, increases hypertension, does a lot of stuff. It's like, if we look at it like a domino effect. Once one domino falls over, other mechanisms compensate, and so on and so on. History. Considerations for history. Accurate history may be the key to suspecting a bleeding disorder. Many patients know they have a bleeding disorder. However, some may be unaware. History of present illness. Considerations. Pathway direction is based off of chief concern, and then whenever you're using a history or trying to obtain a history from these patients, use the OPQRST mnemonic. It's the easiest way to get the elicited information that you need. This is table 23.2 in your book. Historical factors suggestive of a bleeding disorder. Things like easily bruising, purple-colored rash or petechiae, bleeding from the gums from brushing the teeth, heavy menstrual periods, frequent epistaxis or nosebleeds. Past medical history considerations. Patient with a past history of bleeding disorder often know about it and can provide a good history. Patients who have hemophilia or von Willebrand disease seek care for even minor trauma, and that's because they have a bleeding disorder, they're aware of it, and know that there may be a bleeding complication. Examination, considerations. Physical examination depends on the chief concern. Focus on the primary assessment, airway, breathing, and circulation, and correct any issues that are found. Focus assessment of the head, chest, abdomen. If they have painful extremities, joints, and skin should be indicated as well. Assessment. Bleeding disorders may be difficult to detect. Impaired airway, breathing, and circulatory status. Difficult to determine the red flags in the history sometimes on these patients. If they have known bleeding disorders, attempt to detect the red flags, indicating potential serious complications. If you're aware of it, then try to get ahead of the physiology. In treatment, considerations are usually supportive, focusing on optimizing oxygen and delivering by maintaining airway, breathing, and circulatory measures, and then any bleeding control measures that may be indicated. Hemophilia or von Willebrand's disease, often the patient is treated either with cryoprecipitate or fresh frozen plasma. Sickle cell disease-related pain, treated with oxygen, fluids, and analgesia. Various diseases here that we're going to talk about. Idiopathic thrombocytopenia purpura, typically treated by stopping the inciting medication or trigger. Now, thrombotic thrombocytopenic purpura often need to go transferred to a tertiary care center to undergo plasmapheresis. And then DIC, last but not least, truly critically ill patients, and they have a poor prognosis. Excellent supportive care with ABCs and ventilatory management, fluid resuscitation, and bleeding control measures are the key on these patients. Evaluation, consider vigilant monitoring and reassessment, which will give you an alert to any changes in condition. The patient with known or suspected bleeding disorders may develop bleeding during transport. Disposition, considerations, most patients can be cleared at the local community hospital for suspected bleeding disorders. Transport for confirmation. On hemophilia or von Willebrand's disease and minor trauma, transport to the trauma center unless the distance prohibits this. Conclusion. Bleeding disorders. They include a wide range of conditions. Some are hereditary, but many are acquired. Coagulation system can run into overdrive, resulting in multi-system trauma or sepsis. Paramedics have the opportunity to identify issues early in the care.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, SmithArtSamaritanEMSOK.com or 405-492-8243. Thank you.